Okay, again, welcome back. In our last presentation, we finished that third step, which is the planning phase. We've assessed our patient. We have our cluster of cues. We have written our nursing diagnosis or problem statement. We have planned for the care, give with what goals we would like to reach, and now we're going to implement it, meaning we're going to define the interventions and act upon it. This is the action phase. Okay, as usual, we're having trouble making it go to the next. I don't know why the first one, folks, we have trouble moving it on. Okay, if this is the action phase, see I've got ready, stand by, lights, camera, action. This is when we're going to do something about that problem that we have found. And as we go back, we said that that in our planning phase, that we were going to plan for care that was either going to prevent, reduce, eliminate, or improve the problem that we've identified in our problem statement or nursing diagnosis. So with this implementation process, we are taking data from the first three steps. We're going to determine the appropriate interventions. And then we've got to determine the best priority for those interventions to occur. So there are some interventions that we need to do pretty quickly, and then others, just can wait until later. So we've got to think about that. If we are delegating tasks, then we've got to delegate them and do them in the best priority, with the best priority in mind. So here we are ready to implement our interventions. We have to focus on assessing to observe for changes in the patient's status. So let's say that we had gotten an order for a strong pain medication. We give it to the patient, we're going to observe the patient, and in 24 hours, we realize that because the patient has become more mobile, the patient has been doing all the things that we've asked them to do. We give them the pain medication, and they become very drowsy, and they state to you, I don't think I need anything that strong anymore. So we have to continually assess and observe for changes in the patient's status. So our interventions are going to change. For this particular instance, the concept or the nursing problem was pain. The concept would have been comfort, but the nursing, the NANDA would have been related to pain. And usually patients have varying strengths of pain medications. So you're going to assess and observe for changes. This patient is not experiencing as much pain as they were 24 hours ago. So as part of our implementation, assessing, we're going to monitor vital signs. We're going to monitor the pain. So usually there is going to be an assessing intervention in our implementation strategy. We may have interventions on preventing complications. Let's say we have that immobile patient we talked about earlier with the hip fracture. One thing that we want to prevent is constipation, which we talked about earlier, but we also want to prevent skin breakdown from laying in one position too long. So to prevent complications, where we may have an intervention that says reposition the patient every 2 hours. Again, that would also be reducing risk factors. Another idea with reducing risk factors would be ambulating the patient, getting as much as possible, moving the patient to get that circulation going. Reducing risk factors would be lifestyle changes that you teach your patient if they've got high cholesterol, if their blood pressure's up and they have high cholesterol, or if they've just been diagnosed with diabetes. Treating through teaching and providing physical care. So we're going to have some interventions that will be related to treating, like if the patient already has a wound, we're going to assess and observe that wound. We are going to do the correct wound care and reposition the patient to, we're going to do the correct wound care with good aseptic technique to prevent complications and reduce risk factors. Plus, we're going to be changing that patient's position as well. So that's going to be an actual treating through physical care. And then we treat through teaching. We're going to teach that medication to take, we're going to teach that patient to take medication correctly at the correct time of day. Do they need to eat food? And again, we can go back to the diabetes example a few minutes ago. And we're going to have interventions to improve health through health promotion and to achieve a higher level of wellness. We may want the patient to make better choices with their diet. As you can see, that all of these are interrelated. They all are going to have an aspect of assessment to them, and they all are aimed at preventing and reducing risk factors. Teaching will be all through there. So you can see that there's different interventions, but they're all kind of interwoven, and sometimes one depends upon the other. So there's types of nursing interventions. There's the independent, which are interventions, which are within the nursing scope of practice. If you are licensed to practice as a nurse, you may initiate them. They don't need a doctor's orders. The thing like turning every 2 hours. You could have one also, the facility or the physician may have said every 4-hour vital signs, but there is no reason, if you suspect that something's going on with your patient, that there's no reason why you can't do them every 2 hours. Keeping up with someone's intake and output, a lot of times that is a physician order, but we can certainly do that without a physician's order. So there are many things we're going to come across as nurses that we can do independently, and we can write them in our interventions. And some of our interventions are dependent, meaning they're carried out under physician's order. We can give pain medication every 4 hours or as needed if we are trying to manage a patient's pain, and we have put that as one of our NANDAs. But we have to have a physician's order for that pain medication. So that would be a dependent nursing intervention. And then sometimes there's collaborative nursing interventions, and which reflect the overlapping responsibilities of a healthcare team. We could have the patient could be getting physical therapy, and then the nurse would follow up and make sure in her intervention, if we want to improve the patient's mobility, then she can follow up after speaking with the therapist and understanding what kind of exercises the therapist gave the patient. She can follow up and make sure that the patient is doing those exercises, because they're going to have therapy for an hour, maybe every other day or something like that, and she would need to follow up and make sure that that patient is following through. So again, there's three different types of interventions: the independent, dependent, and collaborative. Our interventions need to be safe and appropriate for the individual, and we have to consider a lifespan issues. They have to be safe and appropriate for each patient's age, health, and condition. Now, you will see all through your nursing education, we're going to talk about safe care. Safety is one of the top assessment, and safety are two of the top NCLEX topics that we always come back to. NCLEX wants to know that you can do good assessments and that you can infer what you need to infer from those assessments, and that you are always going to practice safely. So our interventions need to be safe and appropriate for the individual patient's age, health, and condition. If we have an 88-year-old that has issues with their sight, then we are going to want them to be up with assistance. We are not going to be encouraging them to walk in the hall by themselves. So if you have an intervention that you want this patient to ambulate in the halls 3 times, you're going to have to add with assistance. Again, the interventions need to be achievable, and the resources must be available. So if you're in a community and you are doing home health and you need for a patient to eat more protein to help a wound heal, and you have put in your intervention, the patient will increase protein in their diet to assist with wound healing. If you've got that as your intervention, can they afford the meat, the red? You may specify, increase the amount of red meat the patient eats. You have to look, do they have the economic resources to afford the red meat? Or are you going to have to go and figure out other sources of protein for that patient? So it's got to be achievable. And it's got to be congruent with the patient's values, beliefs, and culture. Remember, we said it had to be patient-centered. So what if you had an Asian patient that said because of their religious beliefs they were vegetarian, but yet you needed them to increase the protein in their diet to help a wound heal? You've got to work around that vegetarianism and figure out other sources of protein for that patient. They also have to be congruent with the physician orders and other therapies. You don't want a patient doing activities beyond their abilities if they're in physical therapy. You don't want to go counter to a physician's order. They must be based on the best nursing research evidence. So in the next, I think it's probably in this unit, if not, we will soon be talking about evidence-based care. We want to make sure that we've researched, are we doing the best thing for our patient? There are lots of resources out there. Most hospitals now, particularly with our computerized, with our electronic health records, have built-in resources so that you can research and find what the best evidence, what the best practice is for whatever problem you are encountering and writing interventions for. They need to be within established standards of care as determined by our professional associations, by our state laws, and by the policies of our facilities. Common characteristics of nursing interventions, as we said before, they're patient-centered. They have a specific and concise single action. They're detailed, usually, giving you the information about the action, like when, where, how. They're realistic for the individual patient. They're relevant to helping the patient reach the goal in the planning phase. And you're usually only going to put the top 3 to 5 priority interventions. In clinical, I'm probably going to require 4 or 5. I think when you stop at 3, it's not really helping you make connections. So generally, you will be able to find 3 to 5 appropriate, realistic, relevant, achievable goals, interventions for your patient. And if you realize that the intervention is saying the same thing that your outcome and your goal did, they're patient-centered, but they're going back to that SMART, an acronym. They're specific and concise, they're detailed, they're achievable, they're realistic, and they're relevant to your patient. We're going to base our nursing interventions on specific knowledge from nursing research, evidence, and professional standards of care, which we just talked about that. We want to clearly understand the intervention to be implemented, and we need to question any that are not understood. So another nurse may have written an intervention down. You are not exactly understanding the rationale. When you're in clinical, I'm going to be asking you, what's the rationale behind this intervention? It's important. That's going to relate back to your pathophysiology. So you need to be able to examine these interventions and really understand why we do what we do. We want to adapt the activities to the individual patient. Like the patient we talked about with diabetes that had poor eyesight, it becomes evident to you that they cannot draw up their own insulin. And there's a couple of options out there for you to pick from. If they have the proper resources, you can get a referral to a home health agency. The home health agency can draw up a week's worth of insulin syringes, leave them in the refrigerator for the patient, then the patient can administer themselves. You can also give the insulin, call the doctor and have him prescribe a pen. Now, someone would probably have to set the pen because those little settings are very tiny, but the pens are more expensive. So the home health agency with someone filling those syringes might be the better option. We want to implement safe care. We want to provide teaching support and comfort in our interventions. We've got to respect the patient's ethnic background and cultural preferences. For instance, some Asian cultures have the belief that after childbirth, you are not supposed to shower. There's something in their ethnic background culture. I mean, they will bathe, but they will not shower or immerse their bodies in water for a period of time after the child is born. So if you're on the mother-baby unit and you want the patient to get up and get her shower that morning, it's not happening. So you need to learn to respect that, and you would write a nursing problem related to that, and then with an intervention, respecting that. You want to encourage the patients to participate actively in their nursing interventions. So again, you have to do them with the patient in mind and patient-centered and adapting them to each individual patient. So that brings us to step 5 in the nursing process. We've got to evaluate what we did. That will be in the next presentation. Thank you.